po' di stato. Guardate le montagne dietro di noi.
Stiamo scaricando i lettini da massaggio.
Il muazzin richiama i fedeli al momento della preghiera. Noi domani saremo in cima a quelle montagne.
Guarda dove ti ho portato. Che meraviglia, hai visto il villaggetto?
This is Bruce speaking, first job ever done in Pakistan. We have 4,933 meters and we are making history in a way. Max is coming on the second chopper.
Fai qualche salto, salto, yes boy, ancora, dai amico, fai vedere quello che si fare, yes boy, Cantives, saltone, no, che opportunità, bello, andiamo, non è finito amico, saltino, vai così, yes boy, vai amico, double,
place we flew today to, nobody's ever been there, nobody ever stepped a foot there. So it's exciting. It's just an adventure to start. But you have a unique terrain. It's so big, so high, and so wild, completely undiscovered.
Hi, good morning. Can you hear me?
Yes, sir, we can hear you.
Hello, how are you?
I'm good.
Good, good, good.
Hi, Luis. Good to see you.
Hi. Hello, Hasan.
How are you?
Good,
Not
good.
too bad.
Yeah. Nice 9 a.m. here. Oh, what time is there?
So this is now 5 o'clock in the evening.
Good.
So it is, the whole day is past here already.
Yeah. We are just...
How's everything there?
Good. In quarantine?
And I see, kind of, we have opened our deadlock a bit, but they're opening for 4 days, but it's 9 to 5, and then rest of the time it's deadlock, and then weekend we're off again. So there is quarantine during weekend as well. So, but still, I think we have opened up a little early, so we don't know. We will have to wait and see how things settle. What about in Brazil?
Here in Brazil, some area in the northeast, some city has lockdown. It's terrible, the situation there. But the country is so large. See, in the south, you don't have yet any problem that you can go around, use mask, go around. But the problem is the patient disappear. Nobody want to do surgery. It's like a pandemic of health.
I know. I think it's everywhere, but I think it is hopefully going to get better. That's what we're hoping for, and let's see how things settle. What about our friends in Brazil? Everybody okay?
Yes, perfect. Everybody.
All neurosurgeons are doing well.
Yes. So far.
I can see Hasan Syed is here, who's our co-moderator. Hasan, good to have you.
Thank you very much. I'm excited to be here.
Hello, how are you?
Good, sir. Thank you.
Thank you.
And I'm just going to see if Professor Jooma is come in.
Yes, sir. He's already here. I haven't muted him.
Rashid, are you there?
I'm here.
All right, good to have you. It's
I'm
pleasure
here.
to
I'm
have
here.
you.
Yeah, thank you.
Great. Hasan, do you want to introduce Luis Borba, and then we can start?
Sure. Well, it's really a pleasure to meet Dr. Borba. As we all know, he's a professor and chair of neurosurgery at the Federal University in Brazil, where I believe he graduated medical school from there as well. He completed his training in skull-based surgery at the University of Arkansas in America as well, as having a PhD. As we all know, he's an international expert and has spoken at multiple international countries, lecturing in skull-based surgeries, demonstrating live surgeries as well. He's currently the president of the Brazilian Society of Neurosurgery and president of the World Congress of Cranial-Based Surgery. I think we're all very excited to have you here, and we're really looking forward to your talk on craniopharyngiomas.
Okay. Thank you, Salman. Thank you, Hasan. A great pleasure and honor to me to be here. You know, this pandemic, the world is stopped, but not for the science. You see, you have new friends every day from every part of the world. This webinar will make your world much together. You are seeing so beautiful and lecture, so nice surgeons that you never imagined that you had. People from small countries, from area that you never saw their presentation, big meetings, never had the opportunity. And this webinar gave the opportunity to show great people, especially neurosurgery. We are seeing so nice presentations, so nice videos, so nice dissection, and it makes this world completely different. Today, you are saying that the meeting will be different. I think the speakers will be different. They now this opportunity to the young people to show their job, that they are the beautiful job they are doing, it will stay forever. I will take Professor Salman Sharif for the opportunity to talk to you. I speak as very terrible broken English. I think it's the official language in the world. If you understand that, try to see if my slides can talk for me. I start to share my screen here. We'll talk a topic. I don't know if you can see my.
Yes, we can.
Yeah, you okay?
Yeah.
I start here. It's okay, you can see?
Yeah, brilliant, Borba, this is fine.
Okay, great. I remember the time where you said, as a lot of people say that craniopharyngioma, total removal, total removal, total removal. And the patient in the post-op has terrible complication. That time there was no endocrine replacement, hormone replacement. And Professor Yashagil used to say that craniopharyngioma can be the most beautiful surgical procedure and that terrible post-op, because the complication that you have can be worse that you can imagine. After you change to another point, oh, don't need to do anything. Just biopsy, just drain the cyst and radiation. When you saw either other wing is the disease, the complication from the treatment. You see a lot of patients with small tumor that was partially removal, sent to radiation therapy, now is coming with severe cognitive disturbance, severe endocrinology dysfunction, and severe cerebrovascular abnormalities like moya-moya. This balance in the treatment of any kind of disease make us think different. I always say that we are first doctors after we are surgeons. We need to do what you believe that can do the best for the patient in that situation in our environment. See? It's important to understand what I can do in my area. Today, we are talking with the Zoom facilities, the webinar facilities to around the world. You see, you have more than 100 people sometimes, 100 countries sometimes online. That is different, the way to see the pathology, is way the facilities to treat the pathology. It's very important to understand the disease, what you can do. Craniopharyngioma is not a common tumor, it's a rare tumor. And 2.5 to 4% of all brain tumors. And have two stages, two peaks, one in children, other one in adult, that look similar, but are completely different. The behavior of the tumor, the pattern of growth, and the complication from surgery. The tumor located in the area where the patient can start with visual loss, pituitary dysfunction, or intracranial hypertension, that the great majority of the patients that's coming to us in undeveloped countries. You have to understand how is the tumor, where the tumor goes, the way you can treat. We used to have the very simple plain X-ray in 85% of the children. You have a calcification in the cellular or supracellular area. That make the diagnosis. A very simple X-ray you can do in any part of the world. The CT scan helps us a lot to understand more the pathology, the extension of the lesions, where the tumor goes, the role of calcification, but the MRI helps more yet in the diagnosis to show the relation with other structures, especially the hypothalamus. You cannot miss that craniopharyngioma is not only a neurosurgical disease, it's one endocrinology disease. Especially evaluation, endocrinological evaluation is fundamental in the pre-op, and the post-op is crucial. The ophthalmological exam can depict tumor very early. And it's very important to understand as early we treat this tumor, as the smaller is the lesion, better will be the results. Where it's coming from? It's coming from residual cells of the rat pox that is in the middle here. And the tumor can go intracellular, can go inside the stalk, can grow up, and very rarely can be totally inside the third ventricle. From this here, the craniopharyngeal duct, the tumor can be or intracellular, extend supracellular, and make a big lesion, depending on the size and the stage of the diagnosis. And this relation here may be the most important thing in craniopharyngioma, the relation of the hypothalamus. It will make totally the difference in surgical removal and also in the follow-up and the prognosis of the patient. The degree of invasion of the hypothalamus is the greatest difficulty to remove the tumor and also to give adjuvant treatment. This is the paper to me that in the last years changed the history of how you can see and the extension of removal of the craniopharyngioma. It's the paper of Professor Steno from Bratislava is in Journal of Neurosurgery, I think 2004, that showed the relation of the hypothalamus. You see, if the hypothalamus is displaced up, the hypothalamus can be open like this or can be displaced down. This will orientate the way that you can reach this kind of tumor. If the hypothalamus is going up, if you use this route, maybe you have to pass through the hypothalamus, maybe to have more morbidity. If you have a case like this, see, and the tumor start to go and start to come inside the ventricle, the tumor is coming out in the foramen of Monroe, maybe can show you the best way to treat. In another situation like this, the tumor is totally intraventricular, inside the third ventricle. It's not common, but it's possible to do. In this situation, you found the root. I'm worried today when the people say, oh, I do endoscopy, transnasal, endotranspalatal, something through the nose. You can go through the nose from where you want. Maybe you can come here, on top of the head. The endoscopy changed the way to see the craniopharyngioma. The endoscopy, the transnasal endoscopy, changed the way to remove the tumor from the nose. You can see areas that you never imagined you could see. But it does not mean that all craniopharyngioma need this kind of treatment, the approach. I've seen today a lot of presentations, transnasal endoscopic for everybody. But before to decide the approach, you have to understand where the tumor is going, where the tumor is coming, then you have around the tumor. It's completely different. You do a pituitary tumor that is coming from below. When you have the diaphragma, sometimes a capsule, then from craniopharyngoma that sometimes you have, or of course sometimes not always, you have a small vascular structure that are behind. A perforated that coming from the basilar artery, a perforated sometimes coming from the carotid artery, that you cannot see from the anterior approach. Because this, before decide what to do, we have first to understand the disease. First, before talk about approach, let's talk about the disease itself. We know that the only way to try or to cure the patient of craniopharyngoma is the radical surgical removal, period. Radical, total removal, it means the solid part, the calcification, and the wall of the cyst. If you can reach this, you can talk about cure. But it's not always you can do. And sometimes you try to do this, and the cost is very high. For example, it's very difficult to understand or to see in the pre-op how is the invasion, how is the relation with the hypothalamus. The MRI can give you some information, but it's not 100%. This relation you see just in the trans-op. And the most difficult decision in the surgery of craniopharyngoma is how to remove and why to remove this relation with the hypothalamus. Sometimes looks clean, you are cleaning very well from the hypothalamus, looks perfect, and the patient post-op has severe hypothalamic complication. Maybe ischemia, maybe something related to the structure by themselves. But at least in the first time, you should try to remove the tumor. It does not mean that you get in every case, but you should try. The adjuvant radiation therapy, we know that it works. It's proved the radiation therapy works for craniopharyngoma, of course. See, in the follow-up, you can see the patient, you see that you have a good result. It's a balance. A lot of papers comparing radical removal with partial removal and radiation. There are some series that show very similar results. We know this. But you remember, we have a lot of children. And giving radiation to a children is not the consequences in 1 month, 2 months, 3 months, maybe in years. You can have complication from the radiation therapy that in the development of the children. So it can be forever, can come 10 years, 15 years, 20 years. If you can avoid radiation therapy for children, is the best way to treat this pathology. The another thing is the intracystic chemotherapy. We start with drugs, we send to radium, you send to many things, but you are just gain time, as I showed in the paper, the sequence. This paper is a meta-analysis about the radiation therapy as a adjuvant for craniopharyngoma, show that it really works. Of course works. Of course works. But sometimes you have a price. And more you see the children, more you see the patient, this charge will come. See, you have some consequences of this treatment, but maybe is a armamentarium that you can use. If you cannot remove, if the tumors come back again in difficult position, in difficult location, sorry, it may be it's an option, but always have to be very dedicated indication. But you need to have in mind this: radiation for paracellular lesions. 20% of the case had deterioration of the vision. Okay? 7 times more stroke. In children, you have like a moya disease. You have severe cognitive disturbance from hypothalamus, from temporal lobe, epilepsy, dysfunction, hypothalamic. I know that today the radiation therapy improved a lot. I know today you have better software, better planning. This number of complications is decreasing, but it's not zero. It's not, maybe if you balance it to know the way to treat. I always want to show this about the Hiroshima bomb. Do you know what's happened here? The people in the middle here die, burn. This area here, leukemia. This area here, far away from the bomb, solid tumor. What's happened? The possibility of the radiation have a new tumor is possible. You have to think, it's very low. Okay, it's very low, but it's possible. I'm not against the radiation treatment for craniopharyngioma. I'm against to give as a primary treatment. Let's balance it. This patient will need, this patient will not need. Not to everybody, not to anyone. The intracystic therapy, we start with some drugs. Now have some people use interferon, bleomycin, radiation. If you give you time, bleomycin today, I think nobody's using more, because if the drug is not restricted to the cyst, has a terrible complication, and several patients around the world die of this treatment. Interferon is okay, but last Monday, we have a web seminar with Professor Boop, Frederick Boop from St. Jude Hospital, from New York, from Memphis, USA. In one guy, a smart guy from, I think from Ethiopia, no, remember Ethiopia or Kenya. He asked a very interesting question. Professor, I don't have proton beam. I have no experience to get a radical removal in large tumor. I have here the possibility to do one kind of treatment for tumor with large cyst. Put the Ommaya reservoir in function and decrease the cyst. In these young children, the young child that is start to grow, make get a better result. It was the experience of the guy from Ethiopia. Do you know what Dr. Boop said? We review our patients here. And do you know which is the patient has better quality of life? The patient that they did Ommaya Reservoir, USA. Ommaya Reservoir, puncture the cyst, and the young children can go and grow and go have a better quality of life. In the future, they do a more radical removal or combination of therapy, surgery, and radiation therapy. See, everything depends the area that you are and the best treatment for the patient, not the treatment that you see in the books, but the treatment that you see somebody's doing in any place. Let's start the decision making. It's a very interesting case, very interesting case. A tumor that's coming here, big cella. This one, I think, is 31 years old man, 27, sorry. Okay, a large mass. What's the idea here? The best way to treat this lesion, the patient has vision deficit, okay, and some disturbance of endocrinological disturbance. The best idea in this situation, I believe, comes from the nose, remove the maximum that you can, okay, and maybe follow up. Maybe if you remain some tumor away from optical apparatus, away from the hypothalamus, you can give radiation. If you remain a small piece of tumor, maybe it can remain here. Okay? What they try to do, one guy had a very smart idea. I do this case, puncture the cyst, and just aspirate. This case is not the case that the guy from Ethiopia was telling us. The case that the guy from Ethiopia was telling us was a young child with very severe endocrinological disturbance, with no growth, with big cysts. This case is not for this treatment. This case is surgery to go and try to get a radical removal. Okay, they puncture here. They decompress the cyst. What's happened? The vision improved. Oh, excellent result. After patient, sometime came like this, improved the vision. Now it's coming like this after 1 year and a half. Invasion, the bilateral cavernous sinus, you see, is invasion or dysplasia here. Now the surgery that was difficult, now is much more difficult. What's the problem here? They also did here punction and bleomycin inside, severe inflammatory tissue. They decided, see, tumor is small, now it's tumor like this. Surgery, bleomycin before, treat the tumor, and the vision starts to deteriorate again. And now you have this large tumor like this. Your decision maker for treating that lesion was the problem in this situation. What you see in these situations like this, you came from the nose, you have the dura totally invaded, you have the area, the fibrosis, there is no plane of the artery, no plane of any area. You can clean it. There is a small piece of tumor, remain tumor here. You can clean very well, but you have some lesion here. If I had this patient as a primary treatment, like in this situation here, you could try much better result, much better removal than do the surgery after bleomycin, previous surgery, and other kind of treatment. The decision maker is the most important thing. Let's again talk about surgical treatment of craniopharyngioma. We should believe that the only way to try to cure is remove, but not remove everything in every case. Sometimes you can, sometimes you cannot do it. But what's the trick to do this? You have to understand that you not have just one tool. You are not surgeon of one tool. I always say that skull-based surgery is not the surgery of one approach. When I start the skull-base in the 90s, there was a very famous ENT, I think the best pathologist ever. He was seeing the whole world through the ear. He was taking angiofibroma, juvenile angiofibroma, that's here, from here. He was seeing everything from this area. And he was teaching everybody should do this way. Now what you are seeing around the world, that everybody can see the world through the nose. The endoscope is not a magic. It's only a great and wonderful tool. What you can see with endoscopic surgery is amazing. What you can remove with endoscopic transnasal approach is incredible. But does not mean that I have just one approach and I do the approach from this way. The skull-based surgeon has to go to the lab to learn the temporal bone, to learn the cranio-orbital-zygomatic, to understand the anatomy, to understand how to reach the tumor, independent of the approach that you best know how to do it. If I have endoscope, okay, let's come midline, let's come endoscope. If I come lateral, let's come lateral. Let's understand what's better for each situation. It's very important to understand this. Craniopharyngioma is a classical illustration. Can come from everywhere. The craniopharyngioma can go to everywhere. Sometimes you need the transcalosal, sometimes subfrontal, sometimes frontal temporal, like paternal approach. The great majority of the time, transsphenoidal approach is a great idea, but sometimes you need this. You have to understand that to reach this area, there is not only one route. You have several routes you could go around. You can go frontal or frontal-lateral. It's the paternal approach. I always say that 80% of the skull-based lesions you can remove with paternal approach or retrosigmoid approach. But you need to know the other kind of approach, the petrosal, the anterior petrosal, the posterior petrosal, the cranio-orbital-zygomatic, because sometimes you need. The paternal approach, you can extend and transform in cranio-orbital-zygomatic if you need. The retrosig, you can extend and transform in pre-sigmoid approach, post-sigmoid approach. You can go lateral and do the anterior petrosal approach. And you can go through the nose with microscope or endoscope. Endoscope, the view is much, much better. You see? But the microscope, you can remove safely the great majority of things. I bet you that today, 67% of the surgeries that are made, or I think more than 70%, are made by endoscope, transnasal endoscope. You can remove safely with a microsurgery, with a microscope. But it does not mean that endoscope cannot use. It's the difference. Have to learn the two ways. I do more for pituitary. I do more microscope than endoscope because I have the training. I got to have several cases. I prefer in my hand. I do faster. I do safer. I feel safer. I feel safer. But if you are young neurosurgeon, you are learning this anterior approach, you should learn endoscopy. You should learn endoscopy. It will help you. You have a better view. Have a wider view. I use microscope. I use the endoscope to see around and sometimes to remove. But the thing maybe is a different way. Paternal approach, cranio-orbital approach, cranio-orbital-zygomatic approach, independent. Sometimes you can go just subfrontal. Sometimes you can use paternal approach. Sometimes you have to remove and do cranial orbital approach. Depends on the extension of the lesion. This way, you can plan the surgical procedure. But the decision is the most important thing. I think something wrong here. It's not the transcalosal here. No, okay, sorry. The wrong is not transcalosal here. This patient, very interesting. Please forget transcalosal here. This patient came to me after the guy said, oh, what we were doing in this case, we were coming from here, from the nose, remove this area here. I don't know what's coming, okay? And remove through the nose, and this part, this part we treat for radial surgery. This was the idea for this young guy, 7 years old. What you did in this case, a very simple transceval paternal approach. Okay? You can do a paternal approach. Is extension of the lesion. Open widely the Sivan fissure. Always the open the Sivan fissure is the best way to reach the frontal area. See? If you mobilize and totally free the frontal lobe, you can put a spatula to retract, to keep there, and doing the surgery and remove this lesion. Identify the optic nerve, identify the structure, drain the cyst, and you go slowly doing the surgery and removing the structure. You go faster here. Look, here's the carotid artery, okay? Here's the third nerve. This is the cyst in the preclival area. Who's the basilar artery here? This case was proposed for this guy to come from the nose to get this. What's happening to the cyst? You can dissect it by paternal approach. The tumor giving the role for you. What's the most difficult part? This calcification that's under the optic nerve, sometimes invaded the pituitary stalk. Okay, it's the only thing that I'm worried when the people talk about craniopharyngiomas. I preserve the pituitary stalk. It's perfect. Okay, good. You preserve pituitary stalk. I also preserve pituitary stalk. But there is one situation here. Look at this. See if you can have my mouse here. Pituitary stalk preserved. But the tumor was coming from here. In this case, I removed the tumor, preserved the pituitary stalk, but some cells remain in the pituitary stalk. Do you know what's happened? 1 year later, after very clean MRI in 6 months, there was a small enhancement in the pituitary stalk. The tumor came back in the pituitary stalk. I had to come back, in this case, operate again, and remove the small tumor that was in the pituitary stalk. And the patient now has a 5-year follow-up, no radiation. See, pituitary stalk, oh, very nice. I preserve, very nice. But the tumor was coming from there. What do I do today? If I have an invasion of the pituitary stalk, you can go there and remove this part. And the way, if you can do a radical total removal. You see, the pre and the post-op, see, this was the small enhancement. This came like tumor here 1 year later. Okay, now the patient is very, very well. Another situation like this, 9 years old lady, child, big cyst and calcification. Let's try the same approach. Let's try to do the paternal approach. You remove the maximum that you can. Sorry. Oh, it's coming back. Sorry. I go faster here. You drain the cyst. The cyst gives you the wall. Here's the tentorium. Here's the wall of the cyst. We try to remove the cyst, give you the approach to you. See, here's the middle fossa, it's the left side, okay? Have to remove all the small piece that you had there. See? But in this situation, so large tumor, have to go cell by cell. Try to clean cell by cell. This layer that the cyst, the wall of the cyst, you can try to remove. Not always you can. Not always you can, but at least try. Please, at least try. But try safely. Does not mean go there and cut and remove and damage everything. Try to remove safely. See, you can go and dissect the arachnoid, you go around that, you clean the third nerve, you clean the optic nerve, and you go and doing this. See, and the space is given to you. The problem when you have this large calcification, always there is some remaining tumor in the vessels. It's very difficult to remove these small calcifications that are in the perforators or in the hypothalamus, in the areas there. In large tumor like this, what I do, I remove the maximum that I can. Okay? This way is in the post-op, there is some tumor, maybe you can just follow. If the tumor come back with small recurrence, maybe you can give direct radiation therapy or wait how be the behavior of this tumor. This tumor you could remove, the patient is going okay, see? And the idea is to clean the maximum that you can and to understand the anatomy there. You see follow the third, the tentorium, the basilar artery down, the arachnoid, you see the basilar artery? If you keep the arachnoid to the vessels, is the best way to treat it. But see, there is some calcification around the artery, around the nerve, a small calcification that you try to clean maximum you can. And the hypothalamus invasion also is a big concern in this large tumor. You have to try. It not means that you can, but at least try remove the maximum that you get. Is the patient the post-op? A nice removal. The lady here in the pre and post. You see, you just follow. The tumor will come back. Maybe you give a focal radiation. It means focal radiation, not whole brain radiation. Another situation like this, the tumor is coming here, you see? It's come down. You have a big window here. Look this window. It's the better room that you can get to reach this area. If this tumor is retrochiasmatic like this, the optic nerve will be displaced superiorly. How did the tumors come here, going down here, and come back here? The best way to come in this situation, come like this. See, you have the hood. The endoscope will open the window, you can see this safely. But the endoscope is not magic, I will say. The endoscope is a way to treat. See, you have to use the endoscope, the microscope, the instruments, the curve instrument, have to all the things that we have to help you to remove. See? Let's show the case here. You come endonasal. We will localize the cella. We open the cella. I use in this situation I was using the microscope. Let's come back here. Okay. Okay. This is a view I have with a microscope. Okay. Now I put the endoscope. You see? You never have this view with the microscope. The endoscope gives you this view. See, you can separate the tumor under the chiasm. You see? In my hand, I decide to come back to microscope to remove, but you can do this with the endoscope, no problem. See? Now you come back to the endoscope, look the view that you have. It's unbelievable. You never could see this with the microscope. The endoscope will give you all this information that you see this. In this case, you displace the pituitary lateral. You have this. You see the third ventricle, the chiasm, see all the extensions. Go give me the root, the tumor. I just follow the tumor. If you follow inside, decompress, remove the seed. But this was a special situation. There was no branch or perforators in the wall. It was a special situation. The capsula of the craniopharyngiomas situation was very hard, was easier to remove. You see, but is the way to reach this retrochiasmat? You come from below, the optic nerve will be up, you go directly to the area. And the post-op can get a nice removal coming from below. You see the post-op, you can do a nicely removal too. When you go through the nose, what changed the history? Not only the endoscope. What changed the history was the nasal flap. The CSF leak is going down. See? The flap, the vascularized flap, nasoseptal flap, is the change in the history of endoscopic procedures. Because CSF leak was a big problem. Now it's not so big as it was before. Now we are coming a different kind of tumor. If you remember the paper Professor Steno, you have the two cases. Now, this situation I learned from the hardest way. From the hardest way. This tumor and this tumor looks similar, yeah? Okay, come here, third ventricle. Very easy. Come here, cyst, tumor. Transcalosal approach that everybody used to do. Here's more easy. Solid part, come this. This 9 years old, 12 years old, sorry. This guy was 23, 25. Okay? This patient had endocrinological disturbance. This patient has no endocrinological disturbance. See? Just headache. What I decide to do? Transcalosal, of course, it's coming up. But I didn't realize this situation here. Look at this. Maybe this. Look at this. Completely different. When you go transcalosal, you can extend the approach, open the transchoroidal, and go medially, you see, and widen this approach. You can reach out this area here, and sometimes you can see the basilar artery down. But the floor of the third ventricle is the trick. And the way to decide which approach is related to the floor of the third ventricle. If the tumor is coming below, see, if open or displace it. Look this case here. Large tumor, the solid tumor is coming in the ventricle. You have cyst here, but the solid is coming here. It means that the third ventricle open like this. Open to me. It's coming like this. You can do the called transcalosal approach. You come from the superior surface, come up, go to the midline, identify the pericallosal artery, open the third ventricle, the lateral ventricle, release CSF. Now inside the third ventricle, just find the tumor that is here. You see, was very thin, the fornix, and the tumor start to come here. Let's go faster here. Now we decompress inside the third ventricle, maximum that you can, but sometimes there is a big ball of tumor. You start to decompress to have space to pass through the hole. The foramen of Monroe was not small like this, was big like this. See? This is the fornix. You go one side and the other side. You see the fornix in the middle? One side, the other side, see. And you go there and try to remove, cleaning the arachnoid, go to the structures. The arachnoid doesn't go to the tumor. Here's the basilar artery, you see? The basilar artery here, and the big mass. See, the total basilar artery through the transcalosal. Who gave me the approach? The tumor. You decompress the maximum that you can, as you have a small ball here, and try to see. Maybe you should decompress a little bit more. See, I was afraid to damage the fornix here. You see the tumor here? Looks like big, but not so big. The microscope looks so. The big mass that's coming from the third ventricle here. For incredible that you can imagine, this patient today has memory, is okay. I also cannot believe, but Bishop is very, very, very well. See, here's the posterior, the sella, the dorsal sella, the basilar artery there. You see, here is the pituitary stalk, where the tumor was coming. Oh, I cut the pituitary stalk. Of course, I cut the pituitary stalk. The tumor was there. See, and the whole basilar artery. Who gave me this approach? The tumor. The patient that the post-op has diabetes insipidus, just diabetes insipidus, but don't have any kind of severe complication, hyperthemia, obesity is complication, as you see, very common in children. And the pre and post-op, very nice removal in the axial cut. You can see this. When I get this, I say, oh, I do the same in this case. That case I operate before. This I operate came later. I do the same. I did the surgery. Was beautiful procedure. I don't have the video here, but you can see beautiful procedure. Post-op was like this. Pre, pause, pre, pause. Perfect, no? Very nice removal. I can show this in every meeting. What's happening to this patient? Severe hypothalamic disturbance in the pre-op. She had symptoms in the pre-op, and now in the post-op was much worse. 6th day in the hospital, severe complication, hypernatremia, hyperthemia, difficult to control, obesity, every kind of hypothalamic disturbance. What I learned in this situation here, in this case, what's the difference to the other one? We have the cyst up. If the cyst is up, I believe what's happening is this. The hypothalamus is just invade and displaced. It's not open like the other one. If I come from here, I go through the hypothalamus. If I go through the hypothalamus, I have severe complication. Today, what you do in this situation here, in this case, come from the nose. Or maybe frontotemporal here, but first try from the nose. You do wide approach. You expose bilateral carotid artery. You expose the pituitary gland. You can go displace the pituitary gland down. It can go directly underneath retrochiasmatic approach. Today I do like this. I don't do like this, despite this be a very nice picture in the post-op. Sometimes you have situation like this. It's very common in my area. I think very common in your area also. Large tumor, large cyst that going to everywhere. What to do for this case? Man, now it's difficult, no? Big cyst. I have to remove the cyst. I have to remove the wall or just drain. But how to drain this? See, the brainstem compress. I have to decrease this tumor. Maybe I try to remove the maximum that I can. And in 1985, Professor Hakuba, the greatest Professor Hakuba, I think one of the brightest mind you have in neurosurgery, he described this approach, the transpretossal, transcentorial approach, and its application in the therapy of retrochiasmatic craniopharyngiomas. You come from behind and from below, lateral, behind, and below, to reach from the posterior part, coming from here, displacing the sigmoid sinus, and see in this area here, come from this. Not in the posterior fossa, not in the supratentorial, but transtentorial. And the tumor will be just located here. This approach, after that, Professor Mefti described and clarified the way to treat this tumor and try to reach this. You come from here as a petrosal approach, cut the tentorium, identify the fourth nerve, the posterior communicate. The greatest limitation of the approach is the posterior communicating, okay? Sometimes you can cut the posterior communicating to widen this approach and come and see the tumor from here. It's a different way to see the same pathology. You can do petrosal, extend a little bit more, and you have this. Before you have a big cyst, now you remove totally the mass from this side. What gives me this view? First, the tumor, of course. The tumor gives you some space. And second, the approach. Dr. Mefti, I would say, when you have doubt in any kind of approach, if it's anterior, you use cranioorbital zygomatic. You go to everywhere. When this lateral posterior, you use petrosal approach. Because petrosal approach, you can go anterior petrosal, you can go posterior petrosal, you can go transcondylar, you can go retrosig. You decide. See, in the posterior approach, using the temporal bone as your root is a way to treat lesion of this area. One point here to the young neurosurgeon. The temporal bone is our business. We must learn temporal bone anatomy. We must learn the anatomy of the temporal bone, not to treat disease in the temporal bone like tympanic problems. We want to learn the temporal bone as a way, as a route to reach something. I had to learn the temporal bone to remove the petrous apex. I had to learn the temporal bone to remove the mastoid, to go pre-sigmoid, post-sigmoid, pre or retro-sigmoid. Pre-retro. Sometimes you need pre, sometimes you need retro. It's important to understand temporal bone, to learn temporal bone anatomy, to treat trauma. Sometimes you have CSF leak that's coming from the nose. Oh, where? There is no fracture here in the front. There is a fracture in the temporal lobe, in the temporal bone. Not temporal lobe, temporal bone. Okay? You have to learn the temporal bone to go there and close the CSF leak. It's the only surgery that reproduces totally the training in the lab and the operative field. Is the temporal bone. You know why? Because it's bone. If you train bone, you do bone. There is no blood, there is nothing. Okay? Despite of every beautiful procedure, nice videos, nice case, MRI pre-op, MRI post-op, this is our biggest problem, our biggest concern in craniopharyngiomas. I know that you have here many experienced surgeons, Professor Salman, and many experienced surgeons around the world, in our area and my area that are undeveloped countries. All of us had a case that when finished the procedure say, oh my God, it's very nice surgery. I'm so happy. I can see everything. I feel as the best neurosurgeon in the world. Beautiful surgery, beautiful video. Can publish this. I can show this everywhere. 24 hours, 48 hours, 72 hours, you wanna cry. You say, why I remove so radical that tumor? Now they have a young boy with severe hypothalamic disturbance, hypernatremia, hyponatremia, hyperthermia, every kind of disturbance. After this nightmare, 1 year came obesity, severe disturbance, cognitive disturbance, and you look for the young children, for the young child that was, and now you have a severe disturbance. The most difficult in craniopharyngioma is decide when to stop the removal of the tumor. It's difficult to understand and to decide what's safe, what's not safe. The relation of the hypothalamus is the one that change the treatment of the craniopharyngioma. And unfortunately, there is no image in the pre-op that tell you, you see, okay, in this patient, I will have severe complication. Of course, you have a small tumor away from the hypothalamus, it's okay. But there is this kind of displacement, touching, or invasion the hypothalamus. It's difficult to decide this by pre-operative management. In the trans-op, maybe it's coming cleaning, you can see very well. Sometimes it's attached. When it's attached, very difficult to remove, you know, okay, let's stop it. But sometimes it's coming so easily, and the post-op is not. In my world, in the Latin American world, in the undeveloped country world, what changed the history, not only the surgical technique, of change the history of the post-operative endocrinology treatment, especially this drug here. Very easy to give, very difficult to find sometimes. In Brazil, still, it's not cheap. The government is giving this medication now. All the government in their public health, they give it by free to the population, but it's not easy to get sometimes. It's not cheap, but it's the way to treat. Craniopharyngioma is not only a neurosurgical disease. Craniopharyngioma is a multidisciplinary disease. We have to learn how to treat and decide the best way to do this. Neurosurgery, you learn here. We learn in the lab. I just tell you one thing that I was, in the end of last year, I was in a meeting in Mumbai. Many people from your area there. And I saw a presentation of one of the legends. Can I say legend? I want to say of the giant in neurosurgeon. And just before his lecture, I was talking in another room. And I was saying that I spent 3 years in the lab. 3 years in the lab, training, anatomy, understand. I was going to the doctoral Mefty room to see what he was doing, going back to the lab, the cadaver, try to understand the anatomy, what he was doing, what I can do here, and training in the anatomy. And I was very disappointed when I saw this legend, this giant of neurosurgeon, saying, oh, you have to learn neurosurgery in the OR. You have to go to the OR from the first day. You have to be there learning in the whole day. Of course you have to go. But he complements his statement. Don't lose your time in the lab. I just heard that somebody spent 3 years in the lab. Oh my God. Oh my God. There is no more time. We are not living the era. It's not the era that you are training in the head of somebody. You have to train and prepare yourself for the procedure. Learn with the masters. Watch the masters. See what you can do. See and see again. When I visit somebody, visit again, the neurosurgeon has more experience. Learn from him. But go to the lab and train and learn the anatomy, learn the way to treat, because the anatomy will help you in the procedure. See, it's the most important thing that I believe is to learn with the people. We are traveling around the world, giving lecture, make course, skull-based approach, but I think this is the trick to learn skull-based. Despite of the pandemic, December, Brazil will be clean. Rio will be as beautiful as it is, one of the most beautiful cities in the world. Wait to see all of you here in Brazil in December 7 to 11 to the World Congress of Skull Base. December will be okay. It's summer, beautiful beach, beautiful country, and beautiful people to have you here. You have fun. I'm sure you have fun in Brazil. Thank you very, very, very much. It's a great pleasure to me. Thank you.
Dr. Borba, thank you very much. This is a really great presentation, and I'm sure everyone has learned a lot from your experience and your pearls that you mentioned. And thank you for sharing such, such difficult cases as well. There are a couple questions from the audience. Certainly, I have questions as well. But I also want to welcome Professor Jooma, who's here. As we all know, he's a professor at Aga Khan University, and I'm certain he has some comments as well and from his experiences. Professor Jooma, would you like to say a few words?
He just needs to be unmuted. 1 second.
Yeah, Professor, for a very nice presentation. Thank you very much.
Okay.
Yeah.
So carry on, please.
Thank you very much. Thank you for sharing your experience. So one of the things that I share with you is the generational change where we trained to do these under the with the microscope, but increasingly you realize that endoscopic removal does offer a lot of advantages, particularly when you don't have to go off the side too much. So my question to you is, as your experience unfolds, are you using the endoscope more and getting away from pterygium approaches and the frontal transbasal approaches and so on and so forth? Do you see that your practice is changing, or do you feel that you need to change your practice?
I think my practice is Thank you, Professor, for a great question. I don't know if we can understand. The endoscopy has changed completely the treatment of craniopharyngiomas. What we used to do for transsphenoidal, that was very difficult to remove for transsphenoidal. We tried to remove a small tumor, was not reached for this microscope approach. We used to do by pterygium approach. Now, with the endoscope, you can see more than you used to see with the microscope. And with the endoscope, you can see more. It means that the range of indication by transsphenoidal approach with endoscopic view is larger. I'm doing more patient from below with endoscope and microscope together or separate today than I was doing before. Well, it's changing. Of course, it's changing a lot. But I still have a big concern about the tumor. They have some relate laterally. And craniopharyngioma is not so as pituitary tumor that go into the midline, have a nice capsule, and sometimes is the diaphragm. Craniopharyngioma, there is very small branch, vascular branches coming from behind. Sometimes, or the great majority of the time, you cannot see from in the endoscope. See, sometimes I come from the nose, try to remove, and see, okay, I don't feel comfortable. Let's close here. Let's come back to another approach, from paternal approach. I think when I was younger, I had more hair. I have less hair in white. I was doing the surgery sometimes to myself. I was doing the surgery saying, I can do it. I will do it. Today I do as I believe better for the patient. Paternal approach is still for craniopharyngioma, has lateral extension, wider extension, large tumor, perforators behind, is still the best way to do. Paternal approach and its variation. It's not paternal approach by itself, it means just one small thing. Sometimes subfrontal. Paternal approach give you all decision. Endoscope change the practice, change my life, and it will change the life of many, many surgeons around the world. I don't know if I answered to you.
Yeah, thank you very much. I share your feelings.
Yeah.
Thank you.
Thank you, sir. Thank you.
So there are several questions from the audience that we can start asking, but we also encourage you to raise your hands so that we can unmute you and ask questions as well. So I'll just start with a couple
of Hector.
Oh, sure.
Sorry, we have Hector Hernandez. Sure. Hector, where are you from? Please introduce yourself and you can ask the question. Sorry, Hector, are you there? Can you ask the question? Okay, so you go mute. You want to ask this question, Hasan?
Sure. I think Hector was asking in his question, Professor, what tip can you give for the interhemispheric transcalosal approach with the veins joining the longitudinal sinus? How do you surround them, or what tips do you have for that?
Yeah. First, you do a preoperative MRV. See? MRV to see the veins, okay? To see the veins and try to work between the veins. It's very important to see. The veins are at coronal suture. Behind it, you cannot damage. I always dissect the vein to give me more space. The anterior vein, theoretically, you can cut. In theory, you can cut when it's precoronal vein. See? But I try to save this. But the idea is to dissect the vein to give you more space, try to save the vein. And one trick that I'm using now, I don't know if Professor Isbay is there, people have more experience than me here. I put glue, tissue on the vein. Yeah. See, because the traction on the vein, if you have a tissue there, make it harder, make it more difficult to damage the vein. It's one trick, a small trick. But try to get this view anterior there. But the MRV is very important to understand, to do the window, okay?
Thank you. There's another question from an audience member, Dr. Saad. Are we able to unmute him?
Sure. Saad, please go ahead, introduce yourself and ask the question. Saad, are you there? I think they're all scared.
Yeah.
And I believe Dr. Ibrahim Spee is raising his hands. We can unmute him. Certainly. Does he have? Do you have any comments?
Just 1 second.
Hello, Professor.
Can you hear me?
Yes.
Yes.
Super. First, to say hello to the audience, to say hello to Louise and to my old friend Rashid Jooma. Rashid and I had our training at the Atkinson Morley Hospital back in the 80s, St. George's Hospital in London. We had very good years together. So I'm glad to see him again. Louise, I just want to second what you said. And my views about the craniopharyngiomas are strong, and I've been saying this for so many years. Radical excision is the main treatment of this disease. And I'm happy that you mentioned the papers by Stino of Slovenia and also the papers by Pascal from Argentina. Those people changed our concept about the radical excision of craniopharyngiomas and how the tumor would go into the floor and then sort of insinuate itself into the floor and take the mammillary bodies on the side. So the idea that they inserted in our minds that radical excision is possible without causing damage to the hypothalamic structures. Against the saying that surgery would damage the hypothalamic nuclei, but at the same time, radiotherapy does not. Radiotherapy is the one that causes damage to the hypothalamic nuclei. Imagine doing partial excision and then give radiotherapy for a child. This would make his life miserable, his family miserable, and his country miserable. So I'm against the biopsy and giving radiotherapy. One should go in with the state of mind that I want to remove every ion of this tumor, but not regardless, not on the expense of the patient. Sometimes you have to stop. You mentioned something about the stroke. If the tumor is involving the stroke, I cut it without any hesitation, because if you leave it, the tumor would come back and the misery would come back. I would also like to comment on what you said regarding the Umayya reservoir. And Rashid is here. Umayya is a famous Pakistani surgeon who went to Oxford and from there to the States in the 60s, and he managed to give the idea of putting a catheter into the ventricle, not to treat craniopharyngiomas, but to give some chemotherapeutic agents, give some intraventricular antibiotics. 60 or 70 years later, people are still using Umayya reservoir to treat craniopharyngioma up front. To my mind, this is a crime against humanity. It should not be used. And I refer people to the report by Mayo Clinic, 2018. Umayya reservoir should be given for the final terminal cases where no treatment is available. But to put Umayya reservoir and then drain the cyst and the drain is blocked and repeat the surgery is making the patient's life misery. So thank you for stating those facts, and I'm just seconding what you have said, that surgery is the mainstay.
Thank you, sir. Thank you. I know you have a lot of experience. December, you'll be here in Rio, yeah? You wait till here in December. I want to say something about the reservoir, the Umayya reservoir. I don't know if it was understood. I have here in my country some patient with craniopharyngioma, young child, cachexia. If you try to do a surgery, this patient will have problem. In this situation, is the I don't know if it was understood. The guy from Ethiopia that Monday asked to Professor Boop that in his country it was difficult to him. If they have a big cyst and the patient has no clinical condition for surgery, maybe Umayya reservoir and drain the cyst, you can gain time. You can do a treatment that you is a temporary treatment, I say. I think it's time that patient will improve. You gain weight. You have more time to do the surgery. I think it's the same thing with the intracystic therapy. Bleomycin kill people around the world. Bleomycin, interferon. Some people is using, but not everybody has the same result that the guy that developed the technique. Is strange. I think some of this intracystic therapy the improvement is because they drain the cyst, not only because of the medication. Maybe healthy, let's see. And the other question, there is no way, the only way, the radiation therapy, you have complication, of course you have, but sometimes you need. Sometimes you need. But you have to tailor each case. What we are seeing today in the world is, see, two things in craniopharyngioma. I can come from the nose and remove everything and nothing happens. Nothing happens, perfect. A guy Monday said, I preserve 70% of the pituitary stalk and nothing's happened. I don't know. The tumor is coming from there. And the other point is say, oh, just do a biopsy and radiation, no complication. In my institution, I have a proton beam, I can do everything. It's not this way. They're not doing the best for the patient. They're doing the best part for themselves. See? This we need to teach for the young generation. First, as Dr. Omefte always said to me, Borba, first be a doctor. After, be a surgeon. As a doctor, have to see the patient in contact. As a surgeon, you do the best that you can. Okay, I missed the, hello?
Yes.
Yeah. I missed the.
No, thank you for your perspective there. Another question from the audience member was your experience with endonasal approaches for children. What's your experience regarding the size of the nostrils, you know, as a limitation or not?
Zero experience. For craniopharyngioma, I did two pituitaries, okay? One, I opened here, the columella here, to have more exposure, okay? In the two cases was long time, I did a microscope and endoscope. I think, but for craniopharyngioma, I never did transnasal for craniopharyngioma in children. Ours is a big tumor. It's very difficult to get a small tumor. I'm coming from thing. I have no experience. I cannot tell this. My experience. I have no experience.
We still have time.
I don't know if somebody has experience.
Yeah. Hasan, we have done few cases in kids, but we have taken care of the nose. We had made sure beforehand there's enough approach there, and we have only done that in small tumors, not in big tumors.
Yeah.
And we found that it was reasonable. We used a small size endoscope as well in that. So, you know, you need to tailor made according to the nose itself. Yes, in one patient, we did have to give a side cut incision, but then it heals up very well. And our ENT surgeons do that all the time. So it's okay.
Yeah, and I think also sometimes the limitations people also talk about is whether the sinus is developed or not, but certainly there are people who will drill through the bone itself as an approach as well. So it's certainly an option based on the anatomy, I think. Do we have time for additional questions?
Yeah, I think what we do is I think Imad is getting touchy, showing us this. We'll just show what is on for next few days. On Friday, we have Professor Richard Assaker from Lille. He'll be talking about thoracic disc, his experience, and hybrid surgery from Giovanni Grasso from Italy, from Parma. On Saturday, we have IFNE WFNS endoscopy weekend update, which we have every fortnight. And we're discussing craniopharyngiomas all through the endoscope, all different versions of craniopharyngioma to be done endoscopically. So, you know, it would be nice if people who have attended this to attend that, to have an idea that, you know, you can tailor-made things accordingly. And some of these surgeons I've worked with and I know them well, but also many a times do old-fashioned terional approaches or subfrontal approach or transcalosal approach for that matter. So, you know, all the way, every case is different. We need to do that accordingly. Also, tomorrow we have the third session of the first module that we have for ventricular anatomy. We have had two sessions already. And tomorrow it's on third ventricle. basic and clinical anatomy. And we have Azam from Wisconsin, Hasan, who's here as well, will be there tomorrow. And Dev Pujari from Mumbai would also be moderating tomorrow. So, we'd love it if all of you could join us again. And let's carry on with our questions. I'm sorry.
There was one question about your experience or opinion just in terms of the difference of outcomes regarding radical surgery versus subtotal surgery plus radiation. I know you mentioned this in your presentation, but thoughts on that?
I mentioned there is several papers about this. There are several papers about this. And the follow radical removal and partial removal and radiation, the result would be similar. I have some articles about this. The biggest difference is the complication that you had in the follow-up from radiation. The people from radiation say that sometimes you have less complication of the hypothalamus. I don't say, but you have the complications you have for radiation will be the main concern of this. Of course, if you can remove totally and don't send to radiation, is the best way. But great majority, many times you cannot do it. The biggest question in this craniopharyngioma is you do the radical removal, you try to maximize you can, and you have a small piece of craniopharyngioma close to the hypothalamus. You irradiate or not irradiate? Here's the biggest controversy there. Some people irradiate and the follow-up shape is okay. Some people just wait to see us the best situation. I believe if there is a remote, small tumor, okay, that you couldn't remove, okay, you try, you couldn't remove, and the tumor is there, you should give focal radiation for this. But focal doesn't mean whole brain radiation. Okay?
Thank you.
Radiation works. It's very important. See, it's not doesn't work. Works, but sometimes you have a price. See?
There's also an increasing oncogenic role for BRAF mutations for certain craniopharyngiomas, papillary type. And so I know that BRAF and MEK inhibitors have also been used to treat some of these difficult tumors. Is that an option in terms of like targeted treatments in your country? Or, any thoughts on that?
No, you don't have this here. I think the people from America that don't have, yes, they make the same question to Dr. Boop from St. Jude last Monday. Mm-hmm. They are doing a lot of research on craniopharyngioma. There is no target now. There is no target. One thing that's very, very interesting, when you do craniopharyngioma in adults, the surgery looks easier. The papillary looks like it's easier to remove than in children. The children is like crazy. The tumor go to everywhere. In adults, is more more localized. Maybe it's easier to remove than you get in children. But 80% are in children, are not in adults.
There was an additional question from one of the audience members regarding hypothalamic injury and the risk of hypothalamic injury from an endonasal approach versus a transcranial approach. Any thoughts on that?
I don't know if the endoscope make the difference. I don't know if a tool make the difference. To make the difference is the way that you dissect. Yeah. And the relation with the hypothalamus with the tumor. Sometimes there is just pushing. When you decompress the tumor, comes alone. Sometimes it's like a dentate. You cannot do this. This not make the difference in the endoscope, not make the difference if the cranial approach. The relation is this. Same happen with the optic nerve. Oh, sorry. The optic nerve is a little bit different. Sorry. The optic nerve, when you go for the nose, you touch much less, or almost you don't touch in the optic nerve. When you come from transcranial, you try to not touch, but you touch. Maybe you can have more complication with transcranial than transcranial. But the biggest problem of craniopharyngioma when you go through the nose is to have a lot of perforators behind. The relation of the structure, you never know how it will be. It's different. It's different pituitary and craniopharyngioma. The people that used to do transcranial approach for craniopharyngioma and used to see the craniopharyngioma introduce directly there, relation of optic nerve, relation with the tumor. Not always. There is a very clean plane that you decompress and the arachnoid comes, CSF leak. Great majority of the time, there is some adhesions from the optic nerve and upon the hypothalamus. Yet when you are looking directly, you can see safely. In the endoscope, you are not looking, it's indirectly. Don't know if you can understand. I make him understand, you see. I think it's when the tumor wants to come, the tumor comes. When this adhesion, there is no way to take it from below.
And the final question from the audience member was regarding your management of recurrent cysts. They mentioned that these cysts can be difficult to treat, and what's your strategy regarding that?
It's the most difficult situation. It's the most difficult situation. And I had some cases have recurrent cyst. That was a large one. Okay, we put on my reservoir, drain. It was difficult. You couldn't remove in the first surgery. Maybe can send to radiation, but it's not working so well how you do this for the solic part. In this situation, I think the best way, if you can reach again, you can remove this, would be the best scenario. But it's not possible. Maybe it's an option for the reservoir and drain. If there is no leak, maybe try some intracystic therapy, adjuvanted with radiation therapy. Okay?
Great.
Craniopharyngioma is very difficult.
Yeah.
Luis, that was a great talk. I think we all enjoyed it, and it was really to see your version. And I know you're very passionate about craniopharyngiomas and its treatment, and you have always been the leader. I'm grateful to Professor Rashid Jooma, who took time off to be with us, and it was good that he and Ibrahim Sabi got together. So it's wonderful. Hasan, as always, you're brilliant, and all the audience who joined us, and we learned so much from you. And Luis, we'll continue to bother you, and we will see you in December, definitely. Last year we didn't meet this month, but maybe in December we will.
Okay, thank you.
All right, take care of yourself. Thank you very much. Okay,
thank you very much. Bye-bye.
All right, cheers, bye.